if you press play.
Hello, everybody.
Hey.
Welcome. I don't know why I do hello every time on this stream, but every other stream I just do a single hello. Maybe the pressure of co-hosting makes me feel double as inviting. But welcome to this month's edition of Research Roundtable, your favorite live stream that dives into an interesting topic in the OCD research literature, hosted by an acclaimed researcher, John Abramowitz, and me, a person who ran out of gas on the highway yesterday because I trusted my instincts more than I trusted my gas gauge, and my instincts were wrong. It's okay. We figured it out.
Kyle, I would never have expected something like that would happen to you. You're a university student.
You know, there's quite a bit of idiocy, but I try to put on a front on this stream to make it seem like it's not the case. But beyond the idiocy, my name's Kyle King. I'm a rising senior. I'll be going back to Connecticut in 11 days now at Yale University studying neuroscience. I'm particularly interested in OCD because I think it's a really cool disorder. It's an interesting disorder, and I also have it. So the treatment of the disorder is really important to me. I'm joined by my co-host, John Abramowitz. John, if you want to say a word.
Sure. That's my word. No.
Okay.
I'm John Abramowitz. I'm a professor at the University of North Carolina at Chapel Hill. I don't have OCD, but I have dedicated my career to studying it and treating it and training people to do the same. And I'm fascinated by it and love doing research on it and working with folks who have it. And it is a pleasure to co-host with my friend Kyle.
Oh, stop it, you. And it's a pleasure to be joined today by our two guests. But before I introduce our two guests, I must say a few words. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Further, the International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org. A final announcement. There is a live chat as always, and we love when you put questions in there. We try to get to all the questions we can, and I'm sorry if we don't get to all the questions. But please put your questions in that live chat. Just know that it is live and it's on the internet, so it will live forever. So be cautious of what you put in there and make sure everyone's nice and cordial. But we've never had a problem, so it should go well. Okay, so today we're going to be talking about trauma and OCD. And when I told my parents that this is what we were talking about, my mom said, oh, yeah, I saw a lot of little breakout groups for the conference that was about trauma and OCD. I didn't know that was something that people were talking about. And I've only heard this come up in discussions in the lab at Yale a couple times. And people seem to have vague ideas about how these two might intermingle. But I haven't gotten any clear answers on anything when I've asked questions about it. So I'm really excited for this live stream. I think I'm going to learn a lot. I also was trying to come up with a cohesive structure to follow for the live stream, because normally I put questions in order, and I couldn't do it. There's too much there's too many different theories and ideas, and I got overwhelmed and I just gave up. So I'm hoping that our guest today can answer all my questions. I'll start by introducing you, Heidi. So Heidi Oyoletto, which is a last name that I did not learn how to pronounce myself, I had to ask her, is a fifth-year PhD student in clinical psychology at UNC Chapel Hill. Her research interests center on understanding the mechanisms involved in the development of OCD and trauma-related psychopathology in order to develop more effective interventions. She is also interested in perinatal mental health, including the role of trauma in the prediction of perinatal distress and trauma-informed transdiagnostic treatment for perinatal mood and anxiety disorder. There's an alliteration at the end of your biography there. Heidi, how are you doing?
I'm good. Thank you so much for inviting me. And I forgot to put in my bio that I am John Abramowitz's student. So I've had the pleasure of working with him for the last 4 years.
Wait, I've never seen you before in my life.
Yeah, it's me, John.
Heidi is my senior graduate student as of a month ago. That's really weird.
So John, I expect you to be really tough on her throughout this show.
I am. Well, I don't know. You have to ask Heidi if I'm tough on her.
Okay.
Oh, you mean on today? Oh, absolutely.
Yeah, today.
Absolutely. It's like she's defending her dissertation today.
Oh no, please don't.
You didn't know that, Heidi.
No, I'm not ready.
Our other guest is Dr. Caitlin Pinciotti, another last name that I just learned how to pronounce. She's a licensed clinical psychologist and assistant professor in the Manager Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. Dr. Pinciotti's research focuses on the assessment, conceptualization, and treatment of OCD, trauma, and PTSD. She serves as co-chair of the IOCDF Trauma and PTSD in OCD Special Interest Group and the chair of the SIG's Science and Research Committee. So a perfect person to be asking my questions to. Dr. Pinciotti, how are you?
I'm good. Thanks for having me on.
And I take it you're not one of John's students. No conflict of interest there.
No.
I can't claim you.
So I wanted to start with a question that I thought was simple, and then I thought about it more, and I thought it wasn't as simple as I made it thought it was. What is trauma? Like, how do you define trauma and conceptualize trauma as it pertains to the diagnosis of a mental disorder?
Good question.
That is a great question.
I thought it was simple, and then I thought about it harder.
Yeah, it is very controversial. So according to the DSM-5, there was a work group who, the definition has changed over the years and over the versions of the DSM. But the most recent version defines trauma exposure is exposure to actual or threatened death, serious injury, or sexual violence. And this can be either indirect or direct. So direct would be like experienced or witnessed, and then indirect would be like learning about it happening to a loved one, or repeated exposure to the details of an event through one's job. This is controversial, though. Many people disagree with this definition. I'm sure Caitlin has more to add on that, so I'll pass it to her.
Yeah, it's really a question that it depends on who you ask. You'll probably get a different response. So if you're asking from a diagnostic standpoint, then what Heidi described is exactly on point. And if we think about PTSD, for example, you have to have experienced one of those events that Heidi described in order to be able to even potentially qualify for a diagnosis of PTSD. But certainly that word is used a lot more colloquially in everyday language. And there are experiences too that folks are starting to research more, like racial trauma, that we're trying to figure out, like, where exactly do these things fit in. What's really interesting is that the research is a little bit mixed on this as well, but there's some research that suggests that in terms of mental health outcomes, it's actually more important whether somebody subjectively feels like they were traumatized by an experience versus whether or not it kind of like meets this checklist.
So as it stands now, there's like a couple of discrete options that qualify as trauma in the DSM. And if it's not one of those, then it's not technically trauma diagnostically.
That's correct. Yeah, but less so about the type of event and more so about the threat associated with the event.
Okay. And you also use the word traumatized. What does it mean to be traumatized?
Yeah, I mean that's the question, right? It's a really subjective term, and I think that people would probably use that term differently. I think generally speaking, we would kind of differentiate between what we would call like a potentially traumatic event versus an event that was actually traumatic. So somebody might, if we just had them complete like a checklist of events, they might say like, yes, I've experienced a car accident. And we might say like on the surface, that sounds like a trauma to us. Mm-hmm. But they might say like, but it doesn't really impact me all that much. Like I kind of went through it and I'm fine and I've moved on from it. So even though it kind of technically meets that definition that Heidi provided, it didn't feel as though it traumatized them or had any sort of like impact on their mental health.
And I just want to jump in. I mean, that's such an important point for folks that are listening. And I could go on and have about how the DSM, the Diagnostic and Statistical Manual, there are a lot of problems with that. It's a very imperfect, crappy document, actually, I would say. And just another example of that is exactly what Caitlin and Heidi are talking about, that the DSM lays out, here's what, objectively has to happen to you. And it's black and white. Either you have had the trauma or you haven't had the trauma. And what Caitlin is saying is that that's actually not true. It's more your experience of it, what effect it has on you, or what's the aftermath of it for you, that seems to be more important than just whether you undergo the experience or not. I just think that's really important.
Mm-hmm. Yeah, I agree. I think a lot of people, especially clinicians, are moving more towards that subjective experience of the trauma in order to diagnose and to think about how people's reaction to it might be PTSD or consistent with PTSD, even if they don't actually meet criteria per the DSM for a traumatic experience. I think there are other ways of categorizing it under like other specified trauma or stressor-related disorders, right? And so I think that, yeah, I think lately it's moved more towards people's experience of it. And I think there are other events that also are like widely recognized within like the VA hospital, right? Like things like moral injury that like technically might not meet based on this criterion A definition, but like have been shown in the literature to lead to PTSD, and people are treating this as PTSD. And so I think the concept of trauma is, as defined in the DSM-5, is controversial, and that like lots of different events might also lead to PTSD and other trauma-related sequelae that we are not currently capturing under the criterion A definition.
But can we agree that, even that being the case, do you guys think, because I think this, but again, you guys are the experts, the concept of trauma, traumatized, things like that seems to have become very, very broad, and maybe broader than is healthy, maybe broader than is good for the field. I don't know.
That's where I was going to go with the question.
Okay, good.
Yeah, I would say so. I've heard the expression, like, if everything is trauma, then nothing is trauma, right? Like, initially this word was created to describe a set of experiences that sort of goes beyond what you would expect to happen in like everyday life, right? That even though trauma exposure, broadly speaking, is pretty common, that on a day-to-day basis, we don't go around, with a high likelihood of having experienced trauma at any given time. And so, the downside of using that term to describe lots of different experiences is then we kind of lose that specificity of, there is something that's unique about experiencing, sexual assault, physical assault, those sorts of events, that's just different from kind of everyday stressors.
So there is there a pretty significant counter argument to like traumas in the eye of the beholder, that like, no, there are some limits to what is or is not traumas. It can't just be stubbing your toe, something like that.
Or your teacher looked at, my teacher looked at me, the wrong way, or something like, or somebody called me a name, or, stuff like that.
Yeah, I would say that definitely in, the clinical field, there's an agreement that even though the DSM is imperfect, it does kind of provide those like bumpers that we need in a way that, maybe there are ways that we can kind of flexibly approach things, or if somebody is describing post-traumatic stress symptoms, we can still work with them and kind of work with those symptoms, even if you can't technically provide a diagnosis of PTSD. But I would say that definitely folks who are in this area do feel like there needs to be some kind of like management of that term.
I would say that there are some people who also think that the current criterion A definition is what should be the boundaries of it, like that we should not expand beyond that. And there's been a lot of debate within the field about this, but I think that was what was behind the initial criterion A decision in the DSM-5. So there are some people who are hold very strict to that definition, and I think a lot of people now are more in the middle ground.
And by criterion A, I think you're referring to like criterion A of the PTSD diagnosis. So just for the sake of everyone, what is PTSD and what defines the disorder? Yeah,
good question. I can take a stab at this. So PTSD, in order to be diagnosed with PTSD, you have to experience a criterion A event. And so that's exactly what we were just talking about, the definition of trauma in the DSM-5, which is exposure to actual or threatened death, serious injury, or sexual violence. And then in order to meet criteria for PTSD, you also have to experience re-experiencing symptoms. So those are things like intrusive memories, nightmares related to the event, strong emotional reactions in response to trauma reminders, avoidance, is criterion G, I believe. And so that is related to avoidance of like thinking about the trauma, and then avoidance of situations, places, people that remind you of the trauma. And then there's this other cluster of symptoms, which is changes in mood and cognition. So those are things that you might see with trauma survivors having beliefs that the world is dangerous, or that no one can be trusted after the traumatic event. You also see things like anhedonia and lack of pleasure, lack of connection with others in that symptom cluster. And then the last one is hyperarousal. So this is probably what people kind of think the most about when they think about PTSD, is that like sense of hypervigilance, being really like jumpy, alert, startled, difficulty sleeping, things like that. So that's currently the like symptom criteria that people have to meet a diagnosis of PTSD.
Mm-hmm. And when I was kind of doing a preliminary scan of like this topic in Google Scholar, it seemed like every paper that addressed trauma and OCD focused on PTSD and OCD when it talked about another diagnosis or when there's comorbidities involved. Why not any of the other trauma-related disorders?
So, okay, so you're asking like the other disorders in that chapter, why aren't those considered when we've done research on this topic?
Yeah.
I think it's probably more so an issue of prevalence of those disorders. You know, PTSD is most prevalent. And then, you know, you have adjustment disorder, which is prevalent if you look at like insurance documents and people having to get that diagnosis in order to you know, have their insurance cover their care. But it's you know, a little bit less of a reliable diagnosis to go off of. So it's definitely a good point that there are other trauma and stressor related diagnoses. And PTSD is kind of the main one that gets focused on.
Okay. I think it's time, John. I think I got to jump into the meat of this.
Do it.
So Leah just asked the question, what do you think is the relationship between trauma and OCD? And I was kind of going back and forth in my head about whether we should start with trauma and OCD or go to PTSD and OCD and look at the comorbidity. But why don't we start with trauma and OCD? So I'm going to give that most broad question possible to you two and see where it takes us. What is the relationship between trauma and OCD?
How much time do you have?
Yeah.
I'll kind of like quickly summarize like what we're finding in the research, and then we can kind of go into any of those in more detail if people are interested. So I see Leah's comment about developing OCD at an early age. So we do see a portion of people who believe that their OCD was caused by trauma, or that perhaps they had, you know, already like a genetic predisposition to OCD, and the trauma was kind of the last straw, sort of like, you know, pushing their body over the edge, you know, to kind of develop full-blown OCD. But we know that there are other ways that OCD and trauma can intersect as well. So, you know, trauma can, you know, OCD likes to latch on to whatever it can, right? And so it can latch on to trauma in terms of obsessions, you know, involving themes related to the trauma that someone experienced, or even like compulsions sort of serving the function of either coping with their past trauma in some way or trying to prevent future trauma. In those cases, we see like often this pattern where like when someone is experiencing an increase in one set of symptoms, they kind of experience increases in another set of symptoms in tandem because they kind of like work hand in hand. Those are the biggest things that we've seen kind of play out. But we're really kind of looking into this research a lot more to examine exactly what are all the different ways that trauma and OCD can intersect with one another.
Yeah, that was a great overview, Caitlin, to a very broad question. But I think, like Caitlin said, a lot of the early studies looked at trauma and PTSD kind of synonymously, like as the same construct. And so one of the early studies was looking at relationships between PTSD and OCD symptoms among patients who were getting treated for OCD. And one of the things that they found was that when OCD symptoms were treated, PTSD symptoms actually increased. And so that was kind of behind one of the early theories that Caitlin mentioned, that maybe compulsions are performed to cope with PTSD symptoms and like trauma-related memories. And so maybe the compulsions there were like serving the function of keeping the PTSD symptoms down. And so I think that was one of the theories of like how these things are related. And there's also been a couple other theories related to experiences of sexual victimization and survivors experiencing a lot of disgust after that, and that leading to contamination compulsions, right? So like washing rituals and cleaning rituals to remove the potential contaminants from the sexual assault. And so I think that's another pathway that people kind of saw early on, and there were case studies related to that. And so that kind of garnered interest in this overlap between trauma and OCD.
I'll kind of throw out a couple numbers too, in case there are any like numbers nerds on this call. So Lauren Wadsworth and I actually just presented some of this data at the IOCDF conference last month. We're still actively collecting data for this survey as well. So if people are interested in participating, they can email ocdtraumastudy@bcm.edu. It's my little plug. But so we asked folks who had experienced trauma and who had OCD, what did they think was kind of the relationship between these experiences? And 86% of that sample believed that their OCD and trauma were linked in some way. Whether it was in onset, whether it was in their obsessions, their compulsions, the severity, their core fears, the emotions that come up for them. And 2/3 specifically felt that they used compulsions to help cope with their trauma. Now, this obviously, if we think about like the limitations of research, this is already within a trauma exposed sample. So we don't know, across all people with OCD, what proportion of them believe that their OCD and trauma are linked. But within this particular sample that we had, we found that the vast majority felt that there was some overlap in those experiences.
John, if you don't have a question, I have a question.
No, I'm just kind of thinking that go for it.
Okay.
So I love the numbers too. There's
a lot of stuff to talk about. But the first point you brought up, where you used the word caused, and that's what's the most confusing to me about this literature. So, I mean, to what extent can we say that trauma might cause OCD? How do you study something like that? What theories would make that seem plausible? I guess, what does the word cause mean in this case?
Good question.
Yeah. I can tell you with what's already been done. So I published some work last year. We used a sample of folks with OCD in a residential treatment program. And we asked them just very broadly, like, where do you think your OCD comes from? No priming one way or the other, just kind of like an open-ended question. And then we went in and we coded people's responses. And we found that 44% of them identified like some sort of stressful or traumatic life event that they said in their own words they believe caused their OCD to onset. So to answer your question, it's really, we'd have to put it back on those people to define exactly what they meant by like this caused my OCD. But one way that we can look in the future about this potential causal pathway is to do, longitudinal research, do a study over time where we can, get a group of folks who have just recently experienced trauma and follow them over time and see, who goes on to develop OCD or OC symptoms and who doesn't, and what kind of differentiates those groups. And as long as we're taking into account other things like genetic vulnerability, then we might be able to say with a little bit more evidence that there might be some causal pathways in some people. And that's important to say, that not every single person who experiences trauma goes on to develop OCD. Not every person who has OCD has experienced trauma, or even if they have, they might not necessarily be related at all. But we do think that there is this subset of people where there is this kind of relationship in onset, and we really need to dig into that deeper.
Yeah.
Oh, go ahead, Heidi.
Oh, I was just going to say, so far, there's no prospective research that I'm aware of that has actually looked at this, because that research is really hard to do, right? So you have to get people, ideally before they experience a traumatic event, measure their symptoms, and then after the traumatic event, kind of track their symptoms over time. A lot of people will also try to get people like soon after a traumatic event and then track symptoms over time. But I think if you're wanting to say causal, it's best to get people before a traumatic event, that's really hard to do in terms of research, right? It's really hard to know that people are going to experience a trauma soon and that like we're going to measure them, we're going to follow them.
Well, and to that point, we need to be careful of the bias of the I guess logical error of after this, therefore because of this, right?
Mm-hmm.
You could have people who have a trauma and then, soon after or even years later develop OCD, but it's not necessarily the trauma that led to that. There could have been other factors that we're not measuring. There could be things that are related to both trauma and OCD that might be playing a role. The only study that I hope never gets done, the only way to really figure out if trauma causes OCD would be to take, 1,000 people and right. And you'd randomly assign them to the traumatized group versus the non-traumatized group. They'd have to be randomly selected, randomly assigned. And again, we're never going to do that study. We shouldn't. But it's really hard to figure that out absent a controlled study like that. We're taking guesses.
Mm-hmm. Oh, you go.
Sorry. I was just going to say there have been along those lines some experimental studies, not necessarily conducting a traumatic event, but the dirty kids paradigm, where it's an experimental study where they randomize half the participants to, I think, read a script or listen to a script, imagining themselves receiving a kiss, like an unwanted kiss from someone, right? So that's like a proxy for a traumatic event. And then they afterwards will measure their symptoms, their OCD symptoms. And so they'll measure things like feeling contaminated, right? Like feelings of dirtiness, and then how long people will like wash their hands after going through that experimental manipulation. So there have been some like analog trauma studies looking at that. And they have found that like imagining things like that perceived victimization does lead to more washing behaviors and feelings of contamination. But again, that's not like an actual study showing cause and effect, but it is a proxy for showing this how this might come to be.
Very much so. And in cases, that's a great example of why these kinds of analog studies are really important, because like I said, we never do the real study, but yeah, exactly right. Heidi's doing her dissertation on this topic, so she knows pretty much everything about it. So I'm very impressed that you pulled that out of your brain, Heidi. Very good. A for the day.
Wow.
I guess I have two questions. So like OCD, I've heard thrown out a bunch, gets worse. Your symptoms get worse when you're more stressed. So is there something special about trauma-related stress and trauma, or could it just be like stress makes OCD worse?
Right. Yeah, that it's a great question. I don't think we really have the answer to that yet. And kind of going back to this question about onset and causation and, how do you differentiate those two things? Like, we think of the diathesis stress model as helping us to understand, why some people develop.
What is that? Let's slow down.
I wish I had like a little whiteboard. I could like draw out this little diagram, but essentially it's a theory that helps us understand why we think some people develop certain mental health conditions while others don't. And it kind of takes into account both genetic vulnerability as well as like environmental factors. So the idea is basically like, if you could imagine that there was like some sort of like imaginary threshold that like once you're bumped up over that threshold, you have OCD. That people who already have a really high genetic vulnerability to OCD aren't really going to need that many kind of stressful environmental factors to sort of like bump them up, or they might already, sort of have been born over that threshold. But if somebody has a lower genetic vulnerability, then it's going to require, more kind of compounded stressors and traumas to kind of like create the stress that would sort of push one over the edge into developing OCD.
Okay. And that
the wheels turning.
I've never heard of that model. That model is like pretty well founded and established in psychology.
Mm-hmm.
All right, then I'm just, it's like running out of gas on the highway. It's just a little stupid. I don't know. So is there a sense that like, because I've met a lot of people who will attribute their OCD to trauma and they're certain of it. They're like, yes, it started because of X. And is there just a sense that like there's so many people who say that like 44% of people attribute it to trauma, like you said in your study, that like it must be the case. Like, is that what kind of drives some of this research? Like, there's too many people who claim this for it not to be a thing.
Yeah, I mean, it's an interesting question. Again, it points to the limitations that are inherent in like every research study, that perhaps people are looking for a reason, or like looking for meaning, and there could be this kind of like bias of like, what happened right before I experienced my first OCD symptoms that I can sort of point to. And it might give people meaning in that sense, even if, technically that might not necessarily be accurate. And there is probably no way for us to know with 100% certainty, whether that's actually accurate in those cases. But I know for me, what has driven my research in this area is not only just, kind of the prevalence of these things co-occurring, but also how they impact, the clinical presentation and ultimately like assessment and treatment.
Yeah, that's a great point, Galen. And I think that's something that you oftentimes see, is that there are certain like thematic connections between the nature of the traumatic event and the obsessions and compulsions that people are experiencing, if they are tied in some way. And so oftentimes, say the example of sexual assault and in washing compulsions, right? Oftentimes, if it's related to a traumatic event, there will be like more of a clear connection between the symptoms and the nature of the trauma, or something that they experienced during the traumatic event. And so I think that's a helpful way of understanding, like, are these two related in a way that makes sense to conceptualize this is trauma-related OCD, in the sense that like we want to treat both the trauma and the OCD concurrently. Does that make sense?
Mm-hmm.
Well, and to that end, so Alexandra at 1230 has what I think is an awesome comment. Can't obsessive compulsive like behaviors also just be trauma symptoms, right? Just because someone's feeling contaminated or washing a lot as a response doesn't mean they've developed OCD. And again, that gets back, I'm going to rip on the DSM again. The DSM wants to have it as if these are discrete, separate, diseases. And that's just not the case. You can have, PTSD symptoms that look like OCD. Folks with PTSD often do a lot of checking to make sure the doors are locked, not because they're afraid of, they have an obsessional, maybe you could call it an obsession. Their obsession is that someone's going to break in and re-traumatize them if they've been assaulted before, something like that. Is that part of PTSD, or is that an OCD obsession? I don't know where you draw the line, and I don't know how important that is, because as Heidi was just saying, the treatment, and maybe we'll talk about treatment, but CBT, exposure and response prevention, we use that for both PTSD and for OCD.
Mm-hmm. Yeah, I think that boundary is really difficult to draw. And I think a lot of people have criticized this overlap, saying that, like, yes, it is just PTSD symptoms, right? Like, excessive checking of locks is just a symptom of hypervigilance among people with PTSD.
Yeah.
But I think there's also the side of like, okay, well, what if it becomes so ritualized that PTSD treatment doesn't adequately target the checking, right? Like, what if someone needs to check their locks a certain number of times every night, right? Like, when does it cross the line to OCD, or when is it more important that we think about this and think about treatment from an OCD lens versus just thinking about the PTSD lens?
Yeah, and I would say that's a great point, Heidi, that in those situations where the OCD and the PTSD symptoms are kind of like, arising simultaneously, that, checking the locks is intended to prevent future trauma, but it's also done so in this very like ritualized way, that from a treatment perspective, being able to do that kind of functional assessment, we can really cut down on the ritual associated with that checking behavior while still taking that more like trauma-informed approach. So there's like these kind of like nuances associated with that.
So just because I'm not a master's student, or I don't have a PhD, so I'm not as good at seeing the gray as you guys are. If I were like a clinician and I was trying to figure out, like, is this PTSD symptoms, or is this maybe PTSD that has now become an OCD symptom? Like, what sort of things am I looking for? What heuristics might I use?
I would start first with onset. So in order for a symptom to be a PTSD symptom, it has to have either onset or gotten worse after trauma exposure. So if it's something that has always been this severe, that suggests that it's probably not a PTSD symptom. Then you can kind of look towards like trauma relatedness. So how much does this symptom relate to the traumatic event that the person experienced? And then, you know, what's kind of like the presentation of the symptom. So kind of like what Heidi was describing, like if like, let's say we're talking about a safety behavior, are there kind of like rigid rules associated with the behavior? Is there a lot of kind of doubt associated with it? Like, I feel like I have to keep doing this behavior over and over and over again, versus with PTSD, I might be able to kind of disengage a little bit more easily once I feel like I know the blocks are checked and I can kind of disengage from that. So there are lots of ways we can look at like, how is it presenting? Does it feel like it's more of like the function of OCD versus PTSD? And then I guess that leads into sort of function. What is the function of the behavior? You know, is it intended to prevent trauma? Sometimes in both cases it is, but there might be some other function inherent, and that will sort of drive like, how do we respond to this behavior? The example that I usually give here is reassurance. So we know like in ERP, there's a big emphasis on uncertainty and tolerating uncertainty. And so we really encourage people to kind of lean into uncertainty and resist engaging in reassurance. And so that might mean like doing an exposure and kind of sitting with the uncertainty that this thing that you're really, really afraid is going to happen might happen to you. But in prolonged exposure, which is the gold standard treatment for PTSD, it's also an exposure-based treatment. There's a little bit more leniency in terms of reassurance. So, you know, as we're doing with exposures with someone, let's say if somebody is starting to dissociate and they're kind of being pulled back into the past of their traumatic event, we might do some kind of grounding and kind of reassuring them, you're safe right now. It's not happening to you again. Whereas you wouldn't take that route necessarily with OCD.
Yeah, I had been told that the treatments for PTSD and OCD weren't the same, and like it was important to make a differential because you're going to treat a patient differently. So what are kind of the key features, or is that really it, that differentiate maybe treatment for PTSD and treatment for OCD? And what is prolonged ERP? I've never even heard of that.
Yeah. So prolonged exposure is an exposure-based treatment for PTSD. It comes out of the same camp, you know, Edna-FOA. And so it's very similar in terms of kind of the theory underlying both ERP and PE is, you know, sort of approaching versus avoiding feared stimuli, you know, allowing people to kind of incorporate new information that sort of, you know, can be incorporated into like what we would call like the fear structure. But they're different in terms of their implementation. So PE is a bit more manualized than ERP. There's kind of like, you know, sort of session agendas that you kind of work through. And a really big component of PE is imaginal exposure to the trauma memory. So you would have someone select what we would call like their index trauma, or the trauma that impacts them the most right now. And we would have them kind of like verbally share the story of what happened to them start to finish in a prolonged and repeated way. So kind of like over and over and over again, telling this story, which if anybody that's listening, like kind of shuddered or like had a cringe in their stomach when they heard that, just trust me when I say that a lot of people get to a point where they get really bored telling the story. And they'll say like, I'm just like bored. This doesn't like make me anxious anymore. And that's the point, right? And so imaginal exposure is a really big piece of PE. There's also the other types of like what we would call in vivo exposures, which is similar to ERP, where it's basically like out in the world, what are some of the triggers that we can sort of design exposures to.
Hey, you have anything to add? She nailed it.
That was a great summary. I mean, there are other treatments for PTSD too. So there's cognitive processing therapy, or CPT, which takes a more cognitive route to addressing PTSD and really doesn't involve any exposure. And so I think when we're talking about this overlap and talking about the different treatment approaches, it's more so from thinking of the PE, prolonged exposure lens, and ERP, right? Because if we're wanting to treat both together, that probably makes the most sense because we're using exposure processes to treat both. But like Caitlin said, there are nuances in how you might address OCD within the context of PTSD from an exposure lens, right?
Mm-hmm. And it sounds like if you don't necessarily, if a clinician doesn't like give credence to the PTSD or to a trauma, it can backfire, I guess, in a way. I read a paper before coming here that like if you don't recognize PTSD, then symptoms can get worse as you're trying to treat the OCD.
Yeah, that's definitely true. And I think too, if we think about, in ERP, what are we really trying to do? We're trying to, identify like, what is the core fear that's underlying the symptom level presentations when present. Some folks maybe don't have a core fear, but we think that a lot of folks do have this kind of core fear of like, I'm a bad person, or I'm dangerous. And if we don't kind of dig down at that core fear and really work through that, we run the risk of maybe those particular symptom themes might resolve, but then they might sort of like jump into a different theme. Some people describe their symptoms kind of like jumping from theme to theme, but having this kind of deeper core fear that's similar. And when somebody has experienced trauma, of course, you can see how trauma might inform the core fear that someone has about themselves. And so we're really sort of not doing our due diligence in really understanding the core fear and what it means for that person if we don't consider how trauma might relate to that.
Mm-hmm.
John, this is all reminding me of our conversation about real event OCD.
Yeah.
Because in that, as I recall, it's like there's a particular real thing that happened that you're fixated on and you keep repeating in your head. And I mean, it seems like that could be slippery and look like PTSD in some ways. So are there any examples that you guys have come across, if there are any clinicians on the call, that like it's really hard to make that differential? Like it's really unclear whether or not this is PTSD or OCD. Because I don't think they always come together. I'm sure there's cases where it's OCD that looks a lot like PTSD or PTSD that looks like OCD.
I'll just jump in. I would say yes, that there's sometimes it's like, yeah, what's what, and it's hard to figure it out. Other times it's very clear. What's what. Everybody's so different.
I wanted some examples because I'm confused what it would look like.
What's your question exactly?
Like, can you think, or have you come across any examples or cases in your practice where you've seen people with OCD that might look like PTSD, or it's difficult to tell which disorder we're talking about?
Gotcha. I can share an example. And sorry, I think I didn't understand your initial question.
It's fine.
So an example that I can provide is, I was asked to do a PTSD consult on someone. And the thought from the treatment team was that this person had PTSD because they were engaging in a lot of really significant avoidance of trauma-related triggers. So, both like memories of the trauma and emotions associated with the trauma, but also, things out in the world that reminded them of the trauma. And so just hearing that, you would think like, oh, that sounds pretty, cut and dry PTSD. Let's go the PE route or CPT, like Heidi said, some sort of PTSD focused treatment. But when I met with this person and we did a really thorough differential, it turns out that they didn't have PTSD at all, that it was actually OCD, and that they were engaging in avoidance and compulsions because they had this kind of magical association between the event that they experienced and this kind of like catastrophic belief about something happening in the future. So it was kind of this like magical connection that if I encounter reminders of the trauma, then this completely unrelated thing is going to happen to me in the future.
Interesting.
Yeah, and that kind of gets another question I had a way long time ago, which I think, Heidi, you mentioned that it's informative to look at like what the exact compulsions might be to see if they might be connected to the trauma. Like, I think a trauma, sexual assault, and like cleaning compulsions. Is it always the case that the compulsions line up with what the trauma was, or could you have trauma and then compulsions that seem totally unrelated?
I don't think it's always the case that they're directly related. I think, though, that ideally when you're doing an assessment, you'll find some way in which they may be related, right? Whether that's like some beliefs that they formed because of the trauma, like Caitlin just mentioned, right? The magical thinking. Like, I think usually if it's trauma related in the way that it makes sense to treat the trauma, right, and to address this from a trauma-informed lens, then there will be some link between the obsessions and compulsions and the nature of the traumatic event or the trauma that the person experienced, right? And so I think if we're trying to think of it as trauma-related OCD, then we want to see that there's some link between them, right? Because otherwise, it might not make sense to treat it from a PTSD or trauma-informed lens. Does that make sense? Caitlin, anything to add to that? You've done more clinical work with this population than I have.
Yeah, I'll just add to your point, Heidi, that this case that I just described, you know, when deciding kind of how to move forward with treatment for this person, you know, we determined that it wasn't really necessary to do like an imaginal exposure to the trauma memory. As it turned out, that memory didn't actually like elicit that much distress from this particular person. But we did incorporate trauma-related in vivo exposures because those exposures were hitting on both the trauma and the OCD in that case.
Yeah. Makes sense.
One annoying thing about these streams is if I ever ask a question that has a yes or no answer, I never get a yes or no answer.
You want a yes or no answer?
That's if you talk to any psychologist, you'll never get a yes or no answer. Because it's always like it depends, right? That's
it's dreadful.
Yeah.
Okay, there's been a lot of questions in the chat that I've been trying to read, but I want to ask some of them. So I'll ask the one that was just asked. Can trauma OCD be cured if the trauma is dealt with?
That's a good question. You know, I think the word cured is and I see that it's in quotes probably intentionally because that's a pretty strong word. You know, definitely we can treat trauma related OCD. And there have been kind of some early research that has suggested that can be really effective. There's a paper I published last year, really small sample, and it was retrospective, and you know, we need replication and RCTs and all of this. But it did show that people experience significant improvement in both their OCD and PTSD symptoms when they underwent a concurrent ERP and PE treatment protocol. So they had both symptoms treated at the same time. They experienced really great outcomes. You know, cure, I'm not so sure. We know that, you know, OCD kind of like waxes and wanes over the course of the lifetime. And I think we just don't really have the research to fully answer that question quite yet. Yeah.
And to add to that, so from that question, it seems like maybe the person was also asking, like, if we just target the trauma, will OCD, the trauma-related subside? And I think that probably depends. And I think just from a clinical perspective, if you focus on the trauma itself and the OCD symptoms have already taken on like a life of their own, right? Maybe they already have become ritualized, the person's engaging in a lot of compulsions and has that link, that association between obsessions and using compulsions to like neutralize the distress, relieve the anxiety. I think that might be hard to treat with only focusing on the trauma then, right? Because I think we would want to do ERP in that case. And so I think, I don't know that there's a lot of good research out there, but I think from a clinical standpoint, we would probably want to target both the trauma and the ERP, the OCD.
Yeah, I think of, I've had like an interesting trajectory in my career where I really early on in grad school, I came in with a focus on PTSD and trauma, and then kind of brought in OCD along the way in my graduate career. And so I've worked with people who like, you know, started in the PTSD world and people who started in the OCD world. And I always see this kind of like spectrum where, you know, the PTSD folks tend to be much more gentle in their approach, which is really wonderful because you need that when you're working with trauma survivors, and you run the risk of kind of allowing the rituals to sort of just like take hold and go wild in session and outside of session. And then the OCD folks maybe have more of that sort of like cold turkey, like response prevention, more like accountability approach. And so it's interesting for me to see both sides and kind of try to bring them both to the middle a little bit. And so to Heidi's point, you know, I think if you came from just a purely trauma lens, although that might help process the impact of the event, we might potentially, you know, not be working with the OCD in the most effective way.
Mm-hmm. My OCD therapist certainly did not she took a cut and dry approach.
Yeah.
Let's see. There's another question. What?
I said, as most OCD therapists do.
Yeah. We're just straight up OCD. Yeah. Leah Tulin at 1245 asked, how do you keep trauma PTSD interfering in the treatment of OCD in a patient? Or how do you determine which to treat first?
Good question.
Yeah, this is a great question. I've written a little bit about this too. So my recommendation with this first is to determine whether there's what we would call like a dynamic comorbidity or a static comorbidity. So dynamic comorbidity would be exactly what we've been spending most of our time talking about, where there's some sort of overlap or link between the OCD and the PTSD. Whereas static comorbidity would be kind of what John, I think, mentioned earlier, where like somebody has OCD, they have PTSD, they sort of happen to have both at the same time, but there's no real like intersection between those things. So I would look to that, and I would also look to severity. Is there a really clear primary diagnosis? Like the OCD is clearly really, really primary, and they happen to have PTSD, but it's a static comorbidity and it's much less severe. In that case, we might say, okay, maybe we can kind of tackle the OCD first before we move on to PTSD. But in cases where there's a dynamic comorbidity and or it's really hard to piece apart which is the primary and which is the secondary diagnosis because they're both having this really strong impact on functioning, it's probably best to do some sort of combined treatment, whether it's, you know, doing two protocols concurrently or kind of integrating components at once. You might also find too that even if there was a case where there was a clear primary and a clear secondary, if there's a dynamic comorbidity, that secondary diagnosis might be interfering with treatment. So like I've worked with folks who had really severe OCD and it was clearly primary, but their PTSD and their trauma history was triggered when they were trying to do ERP. And so, you know, it was sending their anxiety and their distress through the roof to the point where they couldn't really stay engaged with their exposures because they were so distressed because it was bringing up all of this stuff all at once together. And so in situations like that, if we would have just continued to try and forge ahead and just only done ERP and not address those other pieces, that probably would not have gone very well.
Mm-hmm.
Yeah. And I think, unfortunately, sometimes it's hard to know ahead of time what is primary and what is secondary, right? Like Caitlin mentioned, it might come up during treatment that you're running up against these blocks, right? That someone's dissociating during ERP because of a trauma history, right? And so I think oftentimes you can go in with a set goal and you may have to change your treatment plan based on how exposure is going and based on information that you're collecting about this person's PTSD or OCD symptoms or trauma history, right?
Just never going to get a simple answer out of you guys.
No.
Okay. We're pressing up against time, but I wanted, because there's a lot of it seems from the comment, there's a lot of people here who suffer from OCD and have trauma experiences. So do you guys have any parting words for a community that wants to know more about this subject? Caitlin, you got the first crack at it.
Okay. I'll try to keep it brief because I feel like I could say a lot. I'll say that you know, the experiences that you're having are a lot more common than I think maybe we have previously thought. And there are still so many more questions than we have answers, which I know has just been like frustrating Kyle to no end today. But folks are working on it, and there are opportunities to get involved in the research to help to understand some of these questions. I'll do another plug if that's okay. We just had a survey go live yesterday that we're hoping to get folks from all over the country. We want representation from all 50 states in the United States. And that survey is brief. And one of the aims of that survey is to understand how many people with OCD have experienced trauma and how many people with OCD believe that trauma has impacted their OCD, because we don't really know that yet. And so, I can drop the link to that in the chat if folks want. But that's kind of what I would encourage folks is to just remain hopeful that there are treatments that work, there's research that's being done, and you're definitely not alone in your experiences.
And on the note of how not alone they are, we didn't say this particular number. What is the comorbidity rate between PTSD and OCD?
So it's upwards of 25% of people with OCD have PTSD at some point in their lifetime.
Okay.
People are begging for the link, Caitlin, if there's a way we can get that.
Yeah, it's not letting me post it.
Yeah, I'm not able to. People have asked me questions in the chat, and I'm sorry if you have. I'm not able to. We're not able to post to the chat, so I'm sorry.
Yeah.
Brennan was on it. And to that note about prevalence rates, I think so in samples of people with PTSD, OCD prevalence rates between 30 to 40% have been documented, which is much higher than the OCD prevalence rate in the general population, which is like 1 to 3%. In terms of parting words, I echo a lot of what Caitlin says, right? So this has been documented for a long time that people who have experienced trauma experience OCD symptoms, and the research is just starting to grow in this area now. And so I think there's been a lot more understanding the past decade about this overlap. And I would say that we're learning a lot more about it. But if people are interested in needing treatment for OCD and PTSD or OCD that's related to a trauma, I think the recommendation would be to go to someone who treats both, right? Someone who has a trauma-informed lens and also has OCD experience, because they are the people who will understand this overlap the best.
And I'll just say, Heidi and Caitlin are two of the world's experts. Heidi is a rising star. Caitlin is a superstar already. Heidi will be there one day. But anything that you see that's coming from these two folks, and there are others as well, read and look for their work, because they're doing it. And someone already called out Caitlin for all the excellent work that she's doing, but these folks really know their stuff.
And I'm happy at the end of this, because my last question about prevalence rates, I got a number. That was it was a discrete value. That was quite nice. Well, yeah, thank you both for taking the time to talk to us. This has been really interesting. I've had a lot of fun. And I only got mad for 5 minutes, so it's fine.
I didn't get mad at all, which is actually rare. Sometimes.
Yeah, normally you're the one who gets a little hot-headed, and
Heidi has this soothing effect.
You guys know what you're talking about. Not everybody that we have on here. I agree.
All right. God, you didn't throw Heidi at any point either. I was waiting for the gloves to come off.
Much later. We do have a meeting this afternoon, Heidi.
Yeah.
Just you wait.
I'll let you know, Kyle.
All right. Keep me in the loop. Just before we go, the online OCD conference registration is now open. Visit iocdf.org/online OCD con to register. This year's online OCD conference will feature 2 days of virtual programming for the entire OCD and related disorders community. I don't know if any of you guys will be there, but I'll be there. So if you want to private message me on Zoom, I'll say hi. And walks are taking place now across the country. Visit iocdf.org/walk to find a walk near you. And this live stream is one of many live streams. You can see the entire schedule of future streams at iocdf.org/peace of mind. All right. Those are all my talking points. Thank you all so much for joining. Caitlin, Heidi, John, thanks for joining the stream. And everyone have a fantastic day.
Take
Thank
care.
you for having us.